Rukaiya, can you give me the countdown?
Yes, sir. I'll give you the countdown. 1 second, sir. Yes, sir. We are live.
Okay. So first of all, thank you for joining on time. And it's our great privilege to have all distinguished faculties for today's meeting. Today's meeting discussion would be on the management of first-line ALK rearrangement in NSCLC. And for that, we have a very privileged to have a distinguished speakers with us. We just wanted to give a brief introduction about our speakers. Dr. Suresh Advani, sir, no need of any introduction, because even though we'd like to give the introduction of Dr. Suresh Advani, sir. Sir is a senior consultant medical oncologist at Jaslo Hospital and Research Center. Sir has awarded the Padma Bhushan in 2012 and Padma Shri by Government of India in the year 2002. And sir has total publications in the tune of 683. So we would like to welcome Dr. Suresh Advani, sir, for this meeting. Today we have a second distinguished speaker with us, Dr. Mukesh Bang, sir. Dr. Mukesh Bang, sir, is a consultant medical oncologist and hemato-oncologist at Alexis Multispeciality Hospital at Nagpur. Dr. Mukesh Bang, sir, first prize for poster presentation at ACC 2019. Also presented many presentations on various oncology topics in CME and panelist for breast, prostate, rectal, and lung cancer CMEs. So welcome Dr. Mukesh Bang, sir, for this live discussion. Today we have third is Dr. Chetna Bakshi, ma'am. Dr. Chetna Bakshi is a consultant medical oncologist at Jupiter Hospital, Thane. Ma'am is a principal investigator and sub-investigator in ongoing clinical trials. She has published a numerous of trials within the oncology space. So we would like to welcome Dr. Chetna Bakshi, ma'am, for this interactive session. Today we have with us Dr. Kaushal Patel, sir. Kaushal Patel, sir, is a senior consultant medical oncologist, Elite Hemato Onco Care Center, and 6 other hospitals across Surat. Sir has a best oncologist in South Gujarat 2018, 2020, and 2021 by Times of India. Also, he has also published a number of clinical trials. So welcome Dr. Kaushal Patel, sir, for this session. And last but not the least, we have Dr. Shruti Kate with us. Dr. Shruti Kate is a consultant and head Department of Medical Oncology at CG Manavta Cancer Center. And Dr. Shruti ma'am is published an article on the retrospective study on the outcome of uncommon EGFR mutation positive, newly diagnosed advanced NSCLC patients. So we welcome all the distinguished faculties for this interactive session. So today's flow would be like Dr. Advani, sir, will set the context for this meeting. After that, Dr. Kaushal Patel, sir, will be presenting his case. And then Dr. Mukesh Bang, sir, will moderate the session. So I welcome you all, and now I hand it over to Dr. Suresh Advani, sir.
Yeah. Good evening.
Good evening, sir.
Good evening, colleagues. I'm really very happy to be here to discuss about the ALK positive lung cancer. As all of you know, lung cancer is not a single disease. Hello. You are able to listen?
Yes, sir. We are able to hear you, sir.
Yeah. So
yes, sir. We can hear you.
I think. As I think the double recording is coming up. Why recording is coming up?
Recording. So
Double
this is being
speaker.
double. No, sir. We can hear you only single voice, sir. We can't hear an echo.
Okay. All right. Then I'll go on. lung cancer is not a homogeneous disease. It's one of the most heterogeneous disease. And all of us have realized that today with the new test, so with the new generation testing, we are able to identify newer and newer mutation. The first among them, which was identified, was the EGFR. And all of us know the success story of the EGFR inhibitors. However, later on, the ALK, which constitute about 3 to 6% of the lung cancer, ALK mutation allowed us to identify a new type of the lung cancer. And this was, again, could be targeted. And in terms of the targeted therapy, we have the right from the beginning, the first generation, second generation, third generation, and fourth generation. So we have a crizotinib, the celebrate, alectinib, and lalotinib. And of course, there are many more to come. So today, we are going to discuss about the various types of the ALK mutation and their appropriate therapy. With this, I would like to request the panel to start the next session. Thank you.
Thank you, sir. I would request Dr. Kaushal to present his case now.
Yeah, good evening to all. Can I have a slide, please?
Sure, sir. Kavan, will you share the slides?
Sir, is it possible to share me, because slides are with you only, sir.
Okay, okay.
Kavan, I have emailed the slides. That is the same slide which we are using right now. Yeah, this one. Yes. Thank you. So I have a one case with ALK positive. Can you have a second slide, please? Yeah, these are my disclaimers for the meeting. So I do have one female patient of the 65 years of the age with hypertensive without any other comorbid conditions. She was non-smoker and she presented with the complaints of the progressive headache, left-sided of the weakness of the left upper limb as well as the lower limb, loss of the memory, dyspnea on exertion, loss of the appetite since last 2 to 3 months. When patient was evaluated further for this finding, then she has findings with the MRI brain, which shows that there is a multiple bilateral involvement in the cerebral regions. Largest was found into the right frontal lobe with a significant edema. The PET-CT scan was done and it has similar findings with the brain metastases, primary lung tumors over the right-sided, along with the multiple lymph nodes in surrounding regions. She has been underwent the biopsy and it shows the metastatic carcinoma of non-small cell lung malignancy. Next slide. So this is the PET-CT scan of the particular patients with the primary lung tumors along with the multiple lymph nodes. Next. This is the brain involvement, frontal tumors along with the edema. Next. So she received a whole brain radiation therapy. IHC was done. It was adenocarcinoma and all NGS has been done in this particular patient. And it has been found with the ALK rearrangement positive. She was started upfront on the lorlatinib in view of the brain metastasis. She was tolerating the lorlatinib with the full dose very well. And first PET-CT scan with response evaluation was done on December 2022. And it has found there is a complete metabolic response into the brain as well as into the lung. So near complete response has been documented with the lorlatinib as a first-line therapy. So yeah. So next slide, please. Yeah, so this is the PET-CT scan report post-treatments, and we can found that the tumor has been resolved with the lorlatinib at the end of the 3-month primary as well as in secondary site also. Thank you for this is my brief case presentations.
Thank you, Dr. Kaushal, for your case. We now move on to a panel discussion. I would invite Dr. Bang to take the proceedings forward.
Good evening, everyone.
Good evening, sir. Sir, can we have the full screen, sir?
So first of all, thank you, Pfizer, for this wonderful program. So as Advani sir already has mentioned that it's a heterogeneous disease lung, and every day, every case is a different case. And we face each and every difficulties when we treat these cases and scenarios. That's the reason when we see, just like Dr. Kaushal has showed one case which has shown excellent response after 4 or 5 months of lorlatinib. We also face similar scenarios by using targeted drugs in many of these targeted gene mutations. So I will go ahead with the management of first-line ALK rearranged non-small cell lung cancer. I think all panelists are available. Dr. Kaushal, Dr. Chetna, and Dr. Shruti.
Yes,
All are available.
Yeah. Yes. I'm there. Dr. Chetna is here.
Welcome to the session. So we'll start. So first of all, so the thing is, we know background, second most common diagnosed type of cancer, leading cause of cancer death, all these things we know. I think I'll go ahead with most important things. So the mortality is increasing even after giving so much of therapy, so much of targeted drugs. So estimated number of deaths from 2020 to 2040, it has been increased. So I think we are worried what is happening. So we are trying to see what best as a consultant we can do. So my first question to the panelist is, what is the incidence of ALK mutated non-small cell lung cancer in your clinical practice? I'll start with Dr. Kaushal.
Yeah, approximately 5 to 8% of the populations with NSCLC are ALK positive in my practice.
So in 5 to 8%, how many patients come with the brain metastasis?
Approximately 2 to 3% of the patients. That means we can say if out of 10, we can say approximately 3 to 4 patients are positive with the brain metastasis.
What about you, Dr. Chetna?
So I think in my practice around 3 to 4%. Like I tell you what, I have 3 patients who are ALK positive, out of which 2 patients have they presented with the brain metastasis, and 1 patient presented without brain metastasis. So around 3% I can say out of 100.
And Dr. Shruti?
I totally agree with the rest of the panelists. The incidence is somewhere between 5% ALK positivity, and amongst that, around 3 to 4% will be having brain metastasis.
So, Dr. Shruti, what is your preferred testing platform for ALK?
Yeah,
you do ISC or what?
Yeah, for the metastatic patients, not everyone does an MRI brain at the outset if there are no symptoms. So that could be an under-representation of upfront brain metastasis for certain populations. Many of them are not affording for many tests at the outset. So that is there. And the preferred testing modality is an NGS, because we prefer to do it in order to save the tissue as well as the time. So we do it through the NGS. We don't do it separately, ALK
So
EGFR.
you mean to say a single modality you will be doing if PET is showing the brain lesions, you are okay with it. You don't feel there is a need of MRI, or you don't do in
So
view of cost.
brain, yes, so only if there are many lesions, brain PET will pick it up. Many times it will miss. So if the patient is not symptomatic, PET is not showing brain metastasis, then I am personally not doing MRI brain to find out whether the patient has an occult, brain metastasis. That was what I wanted to say, that all patients may not be symptomatic for brain metastasis at the presentation. So the number of patients that we are giving may be under representation.
So if I say that patient is ALK positive and you have not done MRI, so what you really still you will not do MRI, or what is your take on it?
That will
I'm
start a
just giving
debate.
a tricky question. Just uh,
I agree with what you're saying. I take your point that especially for certain diseases like an ALK positive NSCLC, it makes a difference. But again, we are talking about patients who can take lorlatinib. So in those cases, the guidelines do say that you do an MRI brain. But in general, for metastatic patients, doing an MRI brain is not there as a general guideline for the patients. I mean, if I am correct for the NCCN, it is still not there unless and until it is a localized disease.
no. So I go to Dr. Chetna. What is your take on this?
So actually, I
Whether
mean,
you
as I
will
told
agree
you,
with Dr. Shruti or not?
regarding not doing MRI.
Yes.
So if patient is asymptomatic, but if patient comes ALK positive, I would like to get MRI
Yes.
done. Because if I'm sending NGS, I think patient is that much affording for MRI. So I may not be able to give lorlatinib, but MRI will definitely do because patient may require WBRT.
Okay. Dr. Kaushal, what is your opinion on this?
What do you want to know?
So whether you will be doing baseline MRI for all patients, all non-small cell?
Yes. I have started to do the MRI brain in each and every patients of the non-small cell lung malignancy, along with the PET CT scan or whole body CT scan, because sometimes very small multiple nodules of the brain which has been missed with the PET CT scan. So nowadays I have started to do the MRI brain in each patient, though they are symptomatic or asymptomatic.
So the guideline also have suggested to do MRI brain baseline in non-small cell
Right.
metastasis. Yes.
Right.
So ideally we should do, and if really cost is the issue, as Dr. Shruti told, that cost may be an issue sometimes, but then sending NGS, thinking about lorlatinib and not doing MRI, actually it doesn't justify. But okay, in the cost constraint scenario, you can think about it. But ideally, we should do MRI along with the PET scan to understand the disease status. So coming to Dr. Chetna, do the ALK variant translocation has an impact on outcome of treatment selection?
Oh, why did you ask me this question? I was just wondering to speak. So, okay, I very frankly, I do not know because I was just thinking about this question, but the ALK report in NSCLC just comes like ALK rearrangement, right? So,
Yes.
variant translocation, I mean, I don't know. I mean, I have not seen such patients.
So I think this is a question put by the Pfizer team. Just the reason here. The reason here I'll tell you. The reason I'll tell you why it is like why the question is. See, usually what happens, the first generation, second generation TKIs, they work for the EML4 ALK translocation mutation,
Right.
but there are variant other mutations, also translocations, where the alectinib and drugs don't work, but where the lorlatinib works.
Yeah. But what I understand about lorlatinib is those mutations are resistant clones, right? I mean, which develop after giving. I mean, correct me if I'm
No,
wrong.
there are
Like for
some
yeah.
variant mutations also baseline. They respond to
Yeah.
lorlatinib also. They are baseline also. So,
But does your NGS report tells you about those? Because
so
whatever
previously,
reports I have
yes,
sent,
yes,
yeah,
yes. Previously, it was not showing, but nowadays,
yeah,
because of the new drugs and the more and more deepened molecular testings, now with the invent of lorlatinib saying that they worked on the ALK variant translocations also, I think now the reports will come like that.
hopefully, yes.
Yes, yes. So, even when I saw this question, I was like, so what is the reason? So
Yeah.
the unmet need in ALK positive, we know ALK positive generally are young patients, non-smoker or light smokers. CNS metastasis occur in 20 to 40%, but untreated ALK. But in our practice, as all three of you have told, so I think most of the patients we see with brain metastasis, hardly one or two patients we see without brain metastasis. Otherwise, ALK is positive. Most of the time we see with the brain metastasis. I have a lady who was been treated for brain tumor, and then we check CT chest, and then we found it's ALK mutated non-small cell lung cancer. It was treated
So
outside by.
actually, yeah. Sorry. Actually, both my patients, they came with convulsions. They didn't have
Yes, yes.
any history of, and then they got admitted under neurologist who
Same
did the
happened.
MRI
Same.
brain
Yes.
and then PET was done. Yeah.
Even the neurologist started with the glyma protocol and they started the
Oh
treatment,
dear.
and then they
Okay.
refer to me for their opinion. Then I told it is something else. So this usually we see this ALK scenario like that. So the treatment challenges are always there with the availability of first generation, second generation ALK TKIs, because ALK resistant mutations are there, CNS metastasis, and the inadequate penetration of the various drugs. That's the reason we are going more and more into more targeted drugs from first, second, third generation, similar to EGFR mutations. So this we already discussed, and the only thing here is CNS disease. So at the point of diagnosis. So regarding our discussion by the panelists, so NCCN has already recommended cranial MRI with contrast as a part of pre-treatment evaluation unless patients are stage 1A. So all other patients should be scanned for MRI along with the PET scan or CT. ISMO guidelines also recommended CNS imaging with MRI, and it's preferable to do brain metastasis. Already you know that patient is having ALK mutation. Even if cost constraint is there, you should explain them and try to do MRI, because it changes the treatment plan. So the diagnostic imaging, same thing we discussed. So MRI standard, more sensitive than CT scan, especially for lesions of the posterior fossa. Contrast is preferable because it detects a smaller metastasis. The problem, as Dr. Shruti told, readily not available in all institutes, and then so that is the only issue there. But I think we should do MRI if we have non-small cell lung cancer, and we should screen the brain. And if definitely ALK is there, ALK EGFR, you should always do MRI brain to see. So with this, the MRI is the standard diagnostic imaging technique for detection CNS metastasis. So the question to Dr. Kaushal. So regarding your case, so you mentioned that you gave the whole brain radiation to the patient, which is the case you presented.
Yes, yes.
So in all your scenario, you prefer to do whole brain radiation, or you
No,
think?
no, no. If the patient is so much symptomatic, in my cases, then I would like to go with the whole brain radiation therapy. Otherwise, if the patient is minimal symptomatic or asymptomatic, then we can directly start with the systemic treatments. It will take care of everything.
Okay. So in how many days you get the ALK report at your center?
Can you get me?
In how many days you get the ALK report at your center?
Yeah, I will get the ALK report within 8 days, 8 to 10 days.
Yes. So Dr. Shruti,
Yes,
can you
sir.
hear me? So
Yes, sir.
how you'll manage the case? Matlab, how much disease burden you think that where you feel the whole brain radiation works, or all you can consider single isolated region for surgery or something like that?
So yes, a question of surgery will come if there is a single brain lesion, but of course a contrast MRI has to be done prior to ensuring that it's just a single lesion and nothing more. Uh, so now with these drugs which have good penetration in the brain, WBRT especially can be avoided in all patients. A localized RT can be given if required. Else, we are now moving towards skipping RT for these patients if they are not very symptomatic, and definitely would prefer to start an agent which penetrates into the brain, has a good disease control in the brain. And with the data for ALK NSCLC, the data is without a doubt in favor of lorlatinib. So that would be the starting point, but I would definitely want to avoid a radiation up to the entire brain for a patient who is not very symptomatic.
Okay. What about you, Dr. Chetna? Dr. Chetna, can you hear me?
Sorry, can you hear me now?
Yes, yes, madam. Yeah.
Yeah. So if patient is symptomatic, I'll definitely advise radiation to the patient, because our ALK report takes time to come. So I will advise, and whether it is whole brain or focused, that depends upon the number of lesions. If patient is asymptomatic, then I would like to wait for the report.
Definitely. So the thing here is, so as all panelists agree for it, so the patients with CNS disease at diagnosis. So there are two ways to think about it: either to go for targeted therapies and chemotherapies, or whole brain radiation, or SRS, or surgical resection. So these are the options. It depends upon the clinical scenario and whether it's a limited metastatic disease or extensive disease. And based on this, we decide the local therapies and systemic therapy. I think there may be the opinion varies. Some people don't want to use whole brain radiation, as Dr. Shruti told. If patient is not too much symptomatic, can consider targeted therapy and just wait and watch and see. That option is also a valid option. So go back. Then now I'll ask Dr. Chetna if she is there right now. So what is your preferred first line therapy? So
my preference at this point of time, lorlatinib or alectinib.
No, don't give. Sorry, but right now give one answer to me. I understand. Understand, but you have to give one answer. You cannot be.
Whatever data.
Saying like NCCN.
No, I'll tell you what. So yes, lorlatinib is excellent drug. Data is really good. सिर्फ मुझे लगता है कि alectinib का जो toxicity है, that is little less than lorlatinib. That's what I feel. But lorlatinib is an excellent drug, and I would like to use it as a first line.
Yes, definitely. Dr. Kaushal, I think he's already started lorlatinib, so he will say.
Yeah, my opinion, the best shot is the first shot. So I would like to go with the lorlatinib.
Okay, great. Dr. Shruti?
Yes, I will also prefer lorlatinib. Currently, I have experience of lorlatinib in 3 to 4 patients, but all in the second line or third line setting. But I would definitely want to try it for the first line as well.
So sorry to ask you, in your all cases, what were the first line drugs, and whether the brain metastasis was their baseline?
No, so brain metastasis was not there at baseline, and all these patients have received ceritinib.
Okay. That's good. So I think all panelists agree right now, if the cost is not the issue, and if really we feel that a first line extensive disease with brain metastasis is there, even asymptomatic brain mets, I think we prefer right now with the great data of Crown trial, we definitely wants to go ahead with lorlatinib. But there are crux in that that we'll discuss ahead. So you can see now the NCCN guideline already recommended the category 1 recommendation for alectinib, brigatinib, and lorlatinib. Others are ceritinib and prazotinib. One more question to anyone can take, Dr. Shruti. What is your take on brigatinib? Have you used brigatinib?
No, sorry, I have not used.
Dr. Kaushal, Dr. Chetna?
No, I have just used crizotinib, ceritinib, and lorlatinib.
Okay. Dr. Kaushal?
No.
Even I have not used brigatinib. Sorry, even I have not used. So the treatment sequencing. So we'll start with Kaushal if he is there right now. So what is your sequence? You can tell me.
Yeah, I would like to go with the lorlatinib as the first line nowadays.
I know you are laughing, but I know you are. I understand. But if I say I have a patient who is on alectinib and who has progressed,
then I would definitely go with the lorlatinib.
Not in the brain metastasis type.
I was about to tell that. And I would like to go any of the available options. Then if the patient is affordable, then we'll go with the alectinib. Otherwise with the ceritinib, and on progression, I would like to go with the lorlatinib.
So if I say the patient
crizotinib nowadays in 2020 through crizotinib is no choice right now.
Okay. Now, if I say the patient is on alectinib and the patient has not progressed with the brain metastasis, the systemic progression is there. Still, will be considered using lorlatinib there, or you will think about using anything else, or you will do something else?
No, I would definitely go with the. Yeah. This depends upon how long the alectinib has responded. If there is a short duration of the response with the progression of the symptomatic disease, then we'll go with the lorlatinib. But if the patient is having a long duration of the response, then definitely go with the rebiopsy and see the mutations. And as you mentioned earlier, the mutation status of the different mutation is all rearrangement, and then we'll go with the available options of the lorlatinib.
Definitely, this is the crux here. So if the patient has done well on alectinib, then you can rebiopsy and check what are the variants available, and then you can decide about. Dr. Chetna, so if I say the patient is on alectinib and patient has progressed systemically, so what is, whether you prefer lorlatinib and short duration, if the patient is on alectinib for 3-4 months and patient has progressed, so whether you will be using lorlatinib or you will be thinking about something else, and what you will do?
No, definitely I'll rebiopsy of the lesion. I'll do, and then we'll see whether some of the resistant clones are there. And if there's a resistant clone, then I think one should start on lorlatinib, 100%.
Okay, and if there are no resistant clones, then?
If patient is asymptomatic, no resistant clones, and only PET showing progression, no CNS mets, I would like to continue with the alectinib and see for some more time. But why patient will
you will not be thinking about chemotherapy?
It has to. Yeah, chemotherapy is also one option. Yes. But
Yes.
other patient
If
asymptomatic,
the patient is on ALK therapy.
So if patient is asymptomatic, I would not be hurrying and changing the treatment of the patient.
No, patient is symptomatic. I mean to say the patient is symptomatic, but there is no brain mets.
And rebiopsy is not showing any resistant clone.
Variant mutation, yes.
So I will still start the patient on lorlatinib before starting the chemotherapy. Chemotherapy is going to be my last option.
That only sentence I wanted. Okay, that's fine. Wonderful. So Dr. Shruti, so what is your opinion on this?
So I totally agree. But I still feel that for ALK positive disease, you don't need to rebiopsy if the a patient has not received lorlatinib. We can change to lorlatinib if there is a clear-cut progression. Of course, if the patient is not a candidate for that, we can go for chemotherapy. And if there is a subtle progression, then we can actually hold on, or a progression at a single site, then maybe offer RT at that part, and then continue the treatment. But with the availability
oligometastatic disease.
Yes.
Oligoprogression.
Not oligometastatic, oligoprogression.
Oligoprogression.
But with the availability of lorlatinib, no one would want to do that, because ultimately it is just a matter of 2-3 months where the patient will actually have a florid progression, especially if the PFS is nearing around the median PFS with alectinib. So with the availability of lorlatinib, would want to switch to that. Yeah.
Okay. So you will not be more in favor of rebiopsy if the patient is on first or second generation TKIs?
No, because lorlatinib covers all of that, and for ALK positive, the dropping of mutation doesn't happen. I mean, it will not happen that the patient will become ALK negative. So, I mean, if the patient has not received lorlatinib, I would change to lorlatinib.
Okay. So now the algorithms are two. To the first treatment sequencing, the algorithm one is use first line lorlatinib, followed by, depending upon the clinical scenario, followed by chemotherapy, or use first line second generation TKIs and then second line lorlatinib and then chemotherapy. I think all panelists agree now with the data and to use first line lorlatinib, and we go with the algorithm one. So the first line therapy in patients with CNS disease, other consideration, what you will do? So Dr. Shruti.
Yes, sir. So what is the question?
So if the CNS disease is there,
Okay.
so liquid biopsy is one option. So what is your opinion on it?
Okay, so only CNS disease, and we have not able to reach the diagnosis for ALK positivity. Yes. Okay, so yes, so we have done NGS on liquid biopsy for a couple of patients, and for ALK there is good concordance that it can be done, and definitely we would want to give it a try, the liquid biopsy. Yes. Especially if the patient is a non-smoker female, where we know that the chances of a driver mutation coming positive is higher as compared to a smoker. So we would definitely want to give it a chance. Yeah.
So there is the thought for using CSF for liquid biopsy. So Dr. Chetna.
So this is the question you are asking. Patient has no lung lesion and only CNS.
The lung lesion is there, but if the patient is having a CNS disease and you cannot do biopsy or rebiopsy, I can say.
I will try to do the tissue biopsy.
Sometimes what happens if the patient scenario is a sick scenario where you cannot see, this is the tricky question which this Pfizer people have put forward. So the scenario here is.
I tell you what.
Sorry.
You can tell Dr. Shruti.
No, please go ahead.
Yeah, I was just saying that if the CSF is positive, so if there is a leptomeningeal disease, like just today I saw a breast cancer HER2 positive patient with only CSF positivity, no parenchymal brain disease, PET is absolutely clear, and she was just moving from the neurologist to the ophthalmologist because of the papilledema, and I asked to do a CSF cytology, it came positive. So I think for the positive CSF, I mean, I am also now intrigued that we can prepare maybe a cell block and do the test. So definitely it will be a good way of reaching the diagnosis, because plasma also has its disadvantage that if there is no cell-free DNA in the blood, then it will have a negative report. So if the cell block is positive, then better to go for CSF cell block rather than going for a plasma liquid biopsy, which will have a more chances of being negative, since we do not know the cell-free DNA or the ctDNA value of the blood.
So whether you agree, Dr. Chetna?
I do not know. So practically speaking, what I personally feel is, if patient has got disease in the lung, right? तो ctDNA रहेगा, मतलब it's very unlikely that patient को ctDNA नहीं रहेगा unless it's very what we call it, very small occult malignancy with the brain metastasis. I don't know. I mean, this is very good. We can do CSF liquid biopsy, but I have never done it, or I have not given a thought on that.
This is just a thought process, actually. This is just a thought process which they have put. And I think we should consider, Dr. Shruti rightly told, sometimes we face the scenario where you have a excellent response and there is a disease progression in the brain only. And leptomeningeal metastasis and the primary site is completely responsive. You see similar scenario in HER2 positive patients also. The systemic disease is absolutely fine and the patient is having a leptomeningeal or brain mets where you cannot do biopsy from the vein also, you cannot do from the primary site. So I think in this point, definitely I will be also, Doctor, I will be considering similar to Dr. Shruti that can do CSF analysis and see if we can do a cell block and see what we can check it in. So the summary is, so with this all, newly diagnosed ALK positive, the incidence of brain metastasis 20 to 30%. CNS, you have to do MRI and several ALK TKIs, but all panelists agrees for using lorlatinib first line setting. So, and if it wasn't hard enough to choose one agent first line, we have to think about overall efficacy, overall survival, what's available second line, CNS activity, response rate, progression-free survival. I think as the days are moving from the chemotherapy to targeted therapy to molecular testing, liquid biopsies, everything, I think we are more and more going to deepen and deepen treatment part and considering each and every aspect. So I think what is your second line of treatment, Dr. Chetna, if the patient progress on lorlatinib?
Chemotherapy.
So what regimen you will prefer?
Okay, if it is adenocarcinoma, I would like to use pemetrexed carboplatin.
Happy or keen on using bevacizumab if there is metastatic brain?
That's what I was going to say. I'll add bevacizumab with same carbo.
Okay, Dr. Kaushal, what is your opinion?
Yeah, same as such.
I would. I think he is in the car, so.
We must have reached by this time, I think.
Okay. So then
Dr. Advani has also joined back, sir.
Okay.
Dr. Advani has also joined back.
Yeah. So in this particular subset where the patient progress over the lorlatinib, the question is very difficult. But in this scenario, I would definitely like to do the rebiopsy rather than the progression over the first line TKI, because there is no other option except lorlatinib. But here, the rebiopsy may guide us because there may be the development of some other mutations which give the resistance to the lorlatinib and will help us to give some other TKI, maybe some other mutation like RET or MET or BRAF, something like that. If all other driver mutations are negative, then I would like to go with the chemotherapy as Dr. Chetna has mentioned.
Okay. So Advani sir is there. We asked, I think he will be the best one to give us the idea. Sir, if the patient is progressed on lorlatinib, so what is your opinion, sir?
Yeah, I think that's a situation which is really very difficult. And at that stage, I think new mutation and all, again, it's rare to get the new mutation in this. So I think the chemotherapy is the best answer.
Sir, what chemotherapy you prefer, sir, in your practice? I think you may be having a huge number of patients on lorlatinib, and somehow maybe what is happening?
Failure of target therapy gives you the chemotherapy. Normally, I use gemcite and cisplatin, and along with the immunotherapy also. So I think that can make a thing. So if there's a failure of target therapy, chemo, immunotherapy becomes a choice of the treatment.
And if the patient is having PD-L1 more than 50%, whether can we skip chemotherapy and just can give immunotherapy to the patient?
Absolutely. Absolutely. Definitely.
Okay. Thank you, sir. Thank you very much. So drug design and mechanism of action, I think I'll not go into detail. It's a selective ATP competitive, highly potent third generation TKI, excellent brain penetration, 75% to address the brain metastasis, in improved clinical outcome, and its upfront treatment can completely suppress or at least significantly delay on treatment resistance, leading to more durable clinical benefits. That's it. I think it is informed that it should be used first line, because if you use in second line, third line, the response, PFS response is not that great with lorlatinib than using the first line drug. So I think I'll not go into the details of the. Now comes the rationale for evaluating lorlatinib. The initial phase 2 study was lorlatinib demonstrated intracranial activity in patients with CNS disease, and then it was approved as a first line agent, and then the CROWN trial came. So in untreated patients, results suggested that the lorlatinib may eliminate rare pre-existing subclones harboring ALK resistant mutations or delay the emergence of such resistant subclones. This is the line which I was talking, Dr. Chetna, which they have quoted. Dr. Chetna, can you hear me?
Yes, yes, I can hear you.
So this was the line, the question, the previous question was related to this. The ALK, yeah. So CROWN data, we all know. I think I'll go in brief. The CROWN trial, we know it's a stage 3 or stage 3B4 ALK positive patient who has not received previous any systemic treatment for disease, performance status 0 to 2, and asymptomatic treated or untreated CNS metastases were permitted, and more than equal to 1 extracranial measurable target lesion with no prior radiation. They were randomized 1:1 into lorlatinib 100 milligram or crazaptinib 250 milligram B. The primary endpoint was PFS by BR-CR, and secondary endpoints were PFS, ORR, then intracranial ORR, DR, and then OS, safety and quality of life. No crossover between treatment arms were permitted. So the baseline characteristics, they were subgrouped into lorlatinib, crazaptinib. Equal distribution was there in both areas, and white versus Asian numbers were equal both way, and non-smokers were the most population. So the previous therapy was used in both cases, 6 to 8% patients, and otherwise most of the patients were stage 4 disease and adenocarcinoma. So 18 months follow-up data was there. You can see there is a gross separation of the curves in Kaplan-Meier with a hazard ratio of 0.28. That's a wonderful hazard ratio. So what is your take, Dr. Shruti, on this Kaplan-Meier curve?
It's a very early separation of the curves.
Yes.
And they are as wide as they can be. So so the most favorable curves with any medical oncologist.
I think which a medical oncologist want. Which a medical oncologist want. Okay. So the PFS as 12 months with lorlatinib is 78, and that with crazaptinib is 39. So I think in the interim analysis, lorlatinib significantly prolonged the PFS compared with crazaptinib with hazard ratio of 0.28. The PFS, investigator PFS, here also you can see there is a gross separation of the curves, and 80% PFS rate, otherwise 35% PFS rate with crazaptinib. So I think investigators also agreed that lorlatinib significantly prolonged the PFS if compared to crazaptinib. So if you see the forest plot also here, the all characteristic subgroup analysis favors lorlatinib, works better than crazaptinib. So you can see if the patient is having a brain metastasis, the lorlatinib works beautiful, 0.2 hazard ratio. Non-Asian population here, one point is there which I was just going through. So the hazard ratio is 0.19, otherwise Asians 0.47. Yeah, I wanted to ask this question to Advani sir. So why the difference is there in the Asian and non-Asian population with the hazard ratio of lorlatinib?
Yeah, I think that's a little difficult to understand. But I can tell you that our patients with the ALK positive, they do wonderfully well. I mean, 3 to 6 years is common prolongation. So it is exceptional that ALK will become resistant early. So obviously the responses are good. How much is the real difference? We will not know.
Okay. So, any difference in characteristics like Asian and non-Asian, which can say, or maybe the other mutations which sometimes we see that the patient is having ALK and EGFR mutation. So, rare case reports and rare. I have one patient with EGFR and ALK mutation, both positive. So, in those scenario, what you prefer, sir? If the patient is EGFR and ALK both mutation positive. So how you consider the...
Yeah, that's right. I have treated 2 such cases. Both of them did not respond to the ALK. And EGFR, they responded. So obviously, the EGFR was a major driver mutation, and they responded to that. So somehow I could not get that answer at that time. But at least 2 patients I have treated like that.
I think I have one case, but when I went through the literature and everything, I got the idea that you should treat ALK as a first treatment choice, and then if they are not responding, shift to EGFR. So
Dr. Bang, your patient responded to ALK?
No, same scenario, similar to Dr. Advani sir. So he didn't respond to, and unfortunately, he didn't respond to EGFR also.
So
but at
maybe
that time I didn't use lorlatinib.
Okay.
Yeah. So
no, and we don't know. Our Asian patients are different. They will respond better to EGFR.
Yes. So overall response rate you can see by BICR. It is 76% versus 58% with crizotinib. So significantly more patients in the lorlatinib had an objective response compared with crizotinib. So we know this also intracranial overall response rate, which is 66% versus 20%. We know all this with measurable brain metastasis, 82%, 23%. I will not go into the numbers details, but I think the crux here is lorlatinib demonstrated significantly higher intracranial response rate compared with crizotinib. So time to CNS progression, which is important. Here CNS progression may be the patient didn't have a brain metastasis or a brain metastasis which responded, now progressed. So here also you can see there is a gross separation of, there is a flat line you can see with lorlatinib. So which is not with crizotinib. So in the intent to treat population, time to CNS progression was significantly longer with lorlatinib as compared with crizotinib, and here you can see 0.07%. So hazard ratio again, it's a wonderful, I can say, if the patient is having a CNS disease or even if it is not there, I think lorlatinib is the first choice. So cumulative incidence of CNS and non-CNS progression. Here also there is a delay. CNS progression, definitely there is a delay, and non-CNS also there is a delay, but slightly I can say lesser than the CNS disease. So overall survival. Now this is the question to, I think, Dr. Kaushal.
Yeah.
So the overall survival is not great. So whether you are happy or not.
Yeah, I reasonably okay actually. I'm not much differ in this matter, but there is a separation of the curve, we can say.
I think that separation it will be very difficult to say.
Right. But it's okay. I'm fair enough convinced or satisfied with the data which has been loaded to have with the Crown study. And still I would like to go with the Crown or lorlatinib as a first line treatment option in ALK positive.
Okay. You felt any difficulties with the side effect profile of lorlatinib?
Compared to all other available options, it's a reasonably well tolerable drugs actually. Even when it was not available in India, I have used the lorlatinib on compassionate base of the program from the Pfizer only. And at that moment, the patient has taken the lorlatinib in the second line therapy because of a progression over the ceritinib. And the patient has responded drugs for approximately 24 months in second line. That's quite good.
That's good.
At that moment. And during those 24 months, he has reasonably very well tolerated drugs with the any significant noted side effects.
Okay. So what are your
So I'm
pre-check
comfortable
before?
with the side effect profile of the lorlatinib, or in fact, we can say all other ALK positive except some edema, which has been noted in all ALK positive, particularly for the alectinib is more common, and to a certain extent lorlatinib also.
So what is your pre-check before starting lorlatinib? Whether you do something and just check before starting, or what is?
Yeah, I generally do the test in view of the routine biochemistry, which include the CBC, LFT, as well as kidney function test. And sometimes, very rarely, some of the visual disturbance has been also documented with the lorlatinib, but it's more common with the other TKI. But reasonably, it's a well tolerable drugs.
Okay, Dr. Shruti.
Are you asking about the side effects?
Whether you do any pre-check before starting lorlatinib?
I actually have faced 2 patients who developed dyslipidemia. So I now what I did for the third patient was I did a baseline fasting lipid profile. Though the patient was a young patient, he was 35 or 36-year-old, but I did that and it was fine. And over the later, I mean, assessments did show a dyslipidemia which actually required a statin. So even in the young patient, it could be there. So I now make it a point that I do a fasting lipid profile, so that you know whether it is any baseline abnormality or it has developed later on. And patient is now almost on 1 year is over, and he is doing absolutely excellent. So only dyslipidemia is the one that he developed, and it is now in control.
Definitely,
So that
Shruti,
is the
I definitely agree with your point. Dyslipidemia, hyperlipidemia is an important factor which should be considered before starting lorlatinib, I think, to all patients. Even if Dr. Kaushal has not done, maybe the patient was maybe okay or not too much of dyslipidemia, but I think lorlatinib causes too much of dyslipidemia, and you should baseline check the lipid profile. And if there is a deranged levels, you should start with either rosuvastatin or some other drug, whatever prefers. The antilipidemic agent we should start when before I think starting the lorlatinib.
So,
and
Dr.
another
Bang,
patient.
even sorry.
Yes, madam. Yes.
So even I have one patient only lorlatinib, but that patient also baseline lipid profile was normal, and then patient had to be started on statins, but he's okay. But he was started on statins later on, so we had to start him on
Yes.
some
We need to
statins.
check, madam, actually, because the incidence is quite more. So I think we need to check the lipid profile frequently as we check the routine blood test also.
Yeah.
And
And
whether
edema is also quite common, as Dr. Kaushal said.
yes.
Patients also edema also. Yeah.
Yes. That is also quite common. Yes.
Yeah.
Do agree. So these are the which we are talking. All casualty adverse events with more than 10% difference in frequencies. You can see hypercholesteremia, hypertriglyceridemia, edema, weight increase. These are the commonest side effect adverse events related to lorlatinib. And I think before starting, we should baseline check. So changes from I think the global quality of life also, you can see the difference, and it's good with lorlatinib. So now the 36 months follow-up data is available, and at 36.7 months of median follow-up, the significant still there is a significant longer PFS with lorlatinib than with prazotinib. So we are happy, we are more than happy with this data, and I think we should consider using lorlatinib as a first line agent. Again here, as I told sir, Advani sir, I asked same thing. At 36 months also, you can see here, still the Asian in forest plot, the Asian didn't respond too great in comparison to non-Asian. I think we should think about why this has happened, and we need to consider what is happening. So that is one factor, otherwise all okay. And this same as the previous 18 months data, and it has been consistent with the 36-month follow-up also. So similar here, significantly longer CNS prolongation with lorlatinib. So I think this is what we want to say. And summary of overall and intracranial response, you can see confirm overall response rate is quite good, complete response for patients. So I think we are more happy with the data without any brain mets, with brain mets, metastatic stage 4. All these cases without brain metastasis, we know that lorlatinib is going to work if the patient is ALK positive. So adverse events. So still here you can see permanent treatment discontinuation didn't happen much with lorlatinib than with crizotinib. So that is one important point. But I still feel the side effect profile is slightly more with lorlatinib than alectinib. I personally feel. But if you see the wonderful activity of the drug and PFS, so much of benefit, I think we should consider lorlatinib as a first line choice. So these are all same thing. So the summary of Crown trial at 18 and 36 months we already discussed. So take away from the Crown trial with approximately 18 months of additional follow-ups in the interim analysis of the phase 3 count study, lorlatinib continued to show superior overall and intracranial efficacy compared with crizotinib in ALK positive patients. So this is all. And discussion question, what are your impressions of the data from the Crown trial? We already discussed, but I think I will ask, I will start with Dr. Chetna. She is there. So, and how likely it is impact your first line setting?
So it is amazing data. I mean, as Dr. Shruti rightly said, that is what medical oncologists want to see. In fact, we have not seen such kind of graphs since long time. So really amazing data.
The 0.07 hazard ratio. So
yes. So only thing is there is no head-to-head comparison with alectinib and brigatinib. We anyway know that all these three drugs are better than crizotinib, no doubt about it. But lorlatinib data is really good. It is better than the other molecules.
There is a meta-analysis.
Yeah, and how likely is it to impact means as we have already, I think, agreed upon that we will be using lorlatinib as a first line. So.
Yes. So, Advani sir, so what is your impression of the data from the Crown trial, sir? I think you will be the expert to tell us.
There's no question that we will use the lorlatinib. It has got two advantages. One is, I think because of its effect in the CNS recurrence is prevented. And I think that's a major advance. Yes. And of course, the survival ultimately will come to be superior.
So what about overall survival data, sir? It is not available with lorlatinib.
Yeah, but I think the difference is too wide. So we can't expect that they will join together. They will not join.
Okay. Yes. Okay, sir. So the guidelines. So now we have this guideline. I think, including Advani sir, Kaushal, Chetna, Dr. Shruti, everyone, including me also, I will be happy to start lorlatinib as a first line agent in ALK positive metastatic without brain, with brain metastasis. So a network which Dr. Chetna was asking, a lorlatinib first line treatment with ALK non-small cell network meta-analysis. So here also they have compared the progression with other drugs, and they favored lorlatinib in comparison to other drugs, including alectinib, ceritinib, crizotinib, and other chemotherapy and other drugs. So lorlatinib as an effective first-line treatment for ALK positive non-small cell lung cancer when compared to crizotinib and other next generation TKIs. This is a meta-analysis. So no statistical difference between lorlatinib for OS, or however, as sir was telling, OS was immature for many of the included studies. So this was a comparison, a network meta-analysis, and in terms of PFS, the results indicated that lorlatinib was the best treatment choice for patients with ALK inhibitor naive or untreated ALK positive advanced small cell lung cancer. Future head-to-head trials assessing the relative efficacy are warranted. So I think with this, subgroup analysis and everything there versus alectinib, you can see also in forest plot, you can see still many of the point it favors lorlatinib. Then here one point is here you can see this is the area which I was persistently asking, the Asian population.
Right.
So why this? That's the reason I asked that previous question, why it is like this. The Asian population I think that the plot this is going on the other side, favoring alectinib. So, Sir Advani, sir, I think again, I think we will be clueless about this. So,
there's no really any real reason for that. But the observation is there, and therefore we have to keep on looking.
because here's the difference of, you can see the HR hazard ratio also 1.39. This is drastically on the other side. So I think we should be thinking what to do, because this one area is a gray zone where we don't know. So okay,
Yeah,
as more and more data will come, we'll get the idea.
We have to have some Asian trial where we are head-to-head comparison between alectinib and lorlatinib. That will give us the answer maybe.
In the Asian population.
Yeah.
So ranking wise, we know. Conclusion of network meta-analysis in terms of PFS, the results indicated that lorlatinib was the best treatment choice for patients with ALK inhibitor naive or untreated. So I think with this, what are your, this already we have discussed. We have discussed the side effects. So I think, do you think quality of life? I think we have discussed all of the things. The last question, in first line ALK non-small cell lung cancer patients, how significant are the lipid profile related adverse events? We discussed this also. And here, this is the important point which Dr. Shruti has told. The therapy management for hyperlipidemia, lipid lowering therapy, we have to check whether there is a dyslipidemia, and we have to start the treatment so that we can control a baseline. This is the guideline data for using the therapy as per the cholesterol and triglyceride levels, and you have to start the lipid lowering agent considering these guidelines and the values of the cholesterol and triglycerides. So CNS side effect, this is the one important. Sometimes we see there initially there is a cognitive change in the cognitive functions and those things. So whether you also see similar, Dr. Kaushal, you presented the case. So you felt that there was a CNS effects cognitive change when you started lorlatinib to the patient? Dr. Kaushal, you are there?
Dr. Kaushal, you are on
Yeah,
mute.
yeah. Can you hear me?
Yes.
Yeah. So actually, my patient has initially memory loss due to this the CNS event of metastasis. But as per my experience, I have one experience of 24 months of the lorlatinib in second line. I do not have any significant side effects in form of the cognitive dysfunction with the lorlatinib in that particular subset. Though the experience with the lorlatinib is not so huge, but whatever the experience, I do have approximately 10-12 patients. They are doing quite well with their cognitive functions. Out of these 10-12 patients, I do have 4-5 patients with the CNS metastasis also.
Okay. So Advani, sir?
Yeah,
So,
I think basically the lorlatinib is no question a superior drug, very effective, and it does prevent the CNS problem. And actually, I have one patient whom we treated before the lorlatinib came up. We treated with the crizotinib, patient got resistant, and after resistant development, we again put the patient on the lorlatinib, and the CNS disease responded very well. So I think it's a very effective drug, particularly on the CNS.
okay. No, related to side effect, related to the drug related CNS effects, like the
Side
change in
effects
cognition.
are really minimal in
Okay.
contrast to many other. Here the side effects are very minimal.
Okay, definitely. So, so lorlatinib related CNS effects. So grade 1, you can continue the same dose, or if you feel some the grade 2 or moderate or severe, you can withhold the dose and then re-challenge at the lower dose by 25 mg. And you have to then permanent, if life-threatening side effect is there, you have to stop the lorlatinib. So So this the experts, I think we have asked all experts, have given all the answer, wonderful answers. Do you rebiopsy, which all patients had progression? Definitely. If the duration is more, we rebiopsy and check. Is there any preference while choosing between tissue or liquid? Definitely we choose tissue first. If we don't get, then we think about liquid. Do you believe that there is an unmet need of this area? Can we, what can be done better for the best patient outcomes? So I think we have discussed all of this. Do you believe in sequencing TKIs, or do you think the most potent agent should be used upfront? This is the important question. I think this one question everyone has to answer from Dr. Shruti. Dr. Shruti, you are there?
Yes, sir.
I think fourth
What is the
question. I think now
Sorry,
I am
please.
skipping all other questions, Dr. Shruti. So do you believe in sequencing TKIs, or do you think the most potent drug should be used upfront?
I think that the most potent drug should be used upfront, because at progression, patients' performance status may deteriorate. Many times, patients are unable to use the drug that was kept, on hold for them. So, with such good data in the first line setting, definitely it should be offered to all patients, because I have seen patients who have desperately taken osimertinib in second line, uh, dying within 7 days because it was leptomeningeal progression or something like that. So it happens that those things are not in your control. So when the patient has presented, is in the best PS, that is the best time to use the drug with the most efficient data, or data for that matter. So
Yes.
I would never want to reserve anything for someone who is affording for it at the baseline.
Okay. Dr. Chetna, upfront or sequencing?
I completely agree with Dr. Shruti.
Yes. Dr. Kaushal, any change?
Yeah, I no, I would like to also go with the potent drug as of first rather than doing the sequencing. The same thing like EGFR.
Yes. Advani sir, I think you already told about this.
Yeah,
You
yeah.
will be using definitely lorlatinib.
Lorlatinib.
Yes. Okay. So with this, so I think we should not discuss too much of this. There are so much of mutations which we were talking. Dr. Chetna was asking same scenario. So these are definitely resistant mutations secondary to crizotinib, ceritinib, alectinib, and baseline also you see some variants, and that's the reason we feel ki lorlatinib works better, because it covers the rare variants and mutations also. So that's the reason the third generation. So the ALK G1202R confirms resistance to the available first and second generation TKIs. That's the reason lorlatinib exhibits broad spectrum activity against most known ALK resistant mutation, including G1202R. Similar to, I can say, EGFR osimertinib, I can say the lorlatinib is working. I think it works among most of the variant mutations. So I think I will not go too much into details about this. So key takeaways, we know all this. Treatment new patients, lorlatinib significantly prolongs PFS, highest overall and intracranial response, quality of life improved. Safety profile similar to other drugs. You have to check lipid profile before starting the therapy. And as per the chart, you have to think whether the cholesterol is high or low, triglyceride high or low, and you have to start the therapy. So based on all this, the supports the use of lorlatinib as effective first line therapy with advanced ALK positive non-small cell lung cancer. So I think take home for everyone, and so I think lorlatinib is a wonderful drug. It gives excellent response, and you should start using as the first line agent. Thank you. Thank you, Advani sir. Thank you, Pfizer. Thank you, all three panelists. Dr. Chetna, Dr. Shruti, Dr. Kaushal. Thank you very much. And thank you, Pfizer team and Prashant.
Thank you very much.
Thank
Sir,
you,
Advani sir,
everyone.
one question for you, sir. Not related to this. You are all in front of me. So it's my pleasure. You are sitting. I am seeing you here. So one question for you, not related to this case. So I think Chetna and Dr. Shruti and Kaushal also can take. I have one girl who is 20-year-old, and she is hepatocellular carcinoma with a big necrotic left neck node. And I did a biopsy, and biopsy came out to be biopsy and ISC suggestive of hepatocellular carcinoma in a 20-year girl.
Yeah.
Hepatitis B?
Pardon, madam?
Hepatitis B?
No, all markers are negative, everything negative. So I'm surprised to see the 18, 20-year girl with this. So what should be done?
She has a cirrhosis of liver.
No.
Bevacizumab, atezolizumab.
Surgery is not possible.
Sir, it is extensive neck node
Oh,
along
neck
with the
node.
primary.
Yeah.
It's a big node actually.
Node is positive.
Node is positive. And that also ISC is positive for SCC.
Okay.
So what is
Serum
the
AFP कितना है? Serum
Pardon,
AFP
madam?
कितना है? Serum AFP?
AFP, I think more than 400. If I remember the value, it's more than 4, but it's high. It's very high.
Beva atezol दे दो.
Okay. So the problem here is she is financially poor because I see the patient in Tuklodi Regional Cancer Center also along with Alexis. So that patient is there. So anything I wanted to do something, so I did her NGS panel, and she came met exon 14 positive. So what to do now?
I think these are incidental. It cannot be responsible for hepatocellular carcinoma.
Okay, so that is important point for me, because I started her with lenvatinib first. She didn't respond. Then considering this met exon 14, so she financially not affordable. So I started her on cabozantinib. To see, till that time I asked tepotinib as a compassionate basis from US actually. So, but she was not responding to lenvatinib, cabozantinib. There is nothing. It was just progressing. So I started her on chemotherapy plus bevacizumab, gemcisplatin plus bevacizumab. And after 4 cycles, she has wonderfully responded to the therapy. So, what to do? Anyone can take this, because this is a very dilemmatic, tricky situation for me to treat this case. So
if she has responded, you continue till 6 cycles, no, and then you can give bevacizumab as a maintenance maybe.
So whether we should consider for tepotinib, sir, or madam, anyone?
The patient has not responded to any other anti-met, right? I mean, you have given cabozantinib, you have given TKIs, patient has not responded, no?
Yeah, patient didn't respond anyway.
So I don't know, it's unlikely that patient will respond to any anti-met therapy. That's what I feel. Patient progressed on cabozantinib.
Yes, within 1 month, so, the increase was, it was not like a pseudo progression also. It was clinically, I can see that the node has increased much.
And as Sir has said, this is an incidental finding, very less likely that it is responsible. When I feel the same thing, I don't know. If एक चीज को patient respond किया है, तो why we want to change? ना, we can continue on.
Yeah, but only bevacizumab after finishing gemcisplatin for a 20, 18, 19-year girl. So I was like, whether we should do something else and see something we can do.
Lekin Dr. Bang, patient को metastatic disease, what you expect in HCC in best possible scenario also, right?
The concern is for a 20-year girl to have this such a bad disease. I was just
right.
That was my concern basically. From our side, we are missing something. My thought process is like, we are missing something. I did NGS, I did molecular testing, PDL1, everything I did for that girl.
कोई family history वगैरह कुछ नहीं है?
Nothing is there.
Syndrome में कहीं बैठ सकती है?
No.
Very difficult.
Okay, let's see. Okay. Thank you
give
very
us
much.
the follow-up. You give us follow-up.
Definitely, doctor. Definitely, Dr. Chetna. I'll give you the follow-up. Definitely. Right now, the patient is responding, so till that time, I am happy. But let's see what happens later.
Thank you, Dr. Bang. We'll take a minute to give a small vote of thanks.
Yes.
I'll request Shivani to give a small vote of thanks.
Yeah.
Thank you, everyone. Thank you.
Thank you. Thank you, everyone. Any questions from any of the attendees or panelists? Question?
Rukaiya, are there any questions in the
No,
chat?
sir. No, sir. No questions.
Okay. So I'll just like to thank everybody, the faculty members, Dr. Advani sir, Dr. Mukesh Bang sir, Dr. Kaushal Patel sir, Dr. Chetna ma'am, and Dr. Shruti Kate ma'am for such an interactive session. It was a very wonderfully briefed by Dr. Mukesh sir. And from such a busy schedule, it was a great time to have you all on this platform. We'll be having more such interactive sessions ahead. I will also like to thank all the attendees. There were more than 25 to 30 attendees who have attended this session. So thank you all. And I'll just like to give a brief on our patient assistant program for lorlatinib. We have a patient assistant of like when patient purchase 1 month, then the next month would be free for the patient. And the cost for the therapy is 2,50,000. So the effective cost would be 1,25,000 per month for lorlatinib. Thank you.
Thank you, Shivani. Sir, we are good to close the meeting. Thanks all
Thank
for
you very much.
attending.
Thank you. Thank you.
For taking time out. Thank you, Dr. Chetna.
Thank you, everyone.
Dr. Patel. Thank you, Dr. Kaushal.
Thank you, sir. Bye, sir.
Thanks, Rukaiya.
Thank you, sir. Bye.
Bye.
Thank you.
Thank you, sir. Yeah.